Aloha mai kako. My name is Kekoa, and I wanted to say mahalo to the opportunity for the opportunity to be here today. I am a resident physician at Stanford in the Department of Radiation Oncology and a postdoctoral medical fellow. It's really a privilege to be with you all here today at this Next Generation Faculty Symposium. And I'm very excited to share a topic that I'm very passionate about, which is combating structural racism for Native Hawaiian and other Pacific Islander health data. I want to first ground ourselves in this area that we're going to be talking about today, which is the Pacific. Specifically, I'm from Oahu. I was born and raised in Mililani, up in the mountains, to two indigenous Native Hawaiian parents who sent me to the Kamehameha schools, which was a school founded by Princess Bernice Bohe Bishop as she was dying of breast cancer. She wanted to establish the school for Native Hawaiian youth so that we would remember our culture and our heritage. Growing up, I personally didn't know anyone in my community or ohana who were doctors or researchers, but along my career path, I was lucky to meet mentors like Dr. Fu Tran, who was my PhD advisor while I studied oglochnachalation in the context of lung cancer. I've now had the opportunity to mentor about 20 students of my own from across the country who are all interested in Pacific Islander health. Together, we focus on amplifying Pacific Islander stories through our community's health data. We work on indigenous data, climate health, and health disparities in general. But today, we're going to be talking about combating structural racism, specifically when it comes to Native Hawaiian and other Pacific Islander health data. To frame my research, I'll be discussing the who, what, and why of our work. Starting with who. Up front, I want to be very clear that I do not use this term AAPI, which combines Asian Americans with Pacific Islanders, not only because they comprise completely different and geographically separated populations, but they were legally disaggregated on a federal level since 1997. I want to point out that Asian Americans have origins in countries throughout Asia, whereas these are the Pacific Islands. As you can see, they are not in Asia. Pacific Islanders have ancestry from nearly 30 island nations, states, and territories across Melanesia, Micronesia, and Polynesia. Each of these islands has their own indigenous people, including the indigenous Kanaka Maoli of Hawaii, who are my ancestors. But what brings us all together is our deep-rooted history of oceanic voyaging heritage. Our ancestors skillfully navigated distances longer than the continental United States, navigating island to island using their mastery of the planet and the oceans. Unfortunately, the other thing that brings us together is our long history of colonization. For example, the United States came to the Marshall Islands during the Cold War and detonated an equivalent of over 7,200 Hiroshima bombs, which then displaced indigenous people, led to spikes in thyroid cancer and destruction of land. This may have led to multi-generational trauma, as suggested by our recent studies evaluating radiation therapy refusal when recommended by a physician. We find that today, Native Hawaiian or other Pacific Islanders refuse recommended radiation therapy at the highest rates. When it comes to colonization in Hawaii, many may not realize, but we actually had our own independent and internationally recognized sovereign nation called the Kingdom of Hawaii. However, in 1893, Queen Liliuokalani was held at gunpoint at Iolani Palace and forced to abdicate her throne. Within 120 years of Western colonization, over 95% of our Native Hawaiian population had died due to foreign infectious diseases. Health impacts of colonization persist today, with life expectancies of Native Hawaiian being the lowest of all race and ethnic groups in our indigenous lands. But these numbers are more than statistics. These are my 10 Native Hawaiian ohana diagnosed with cancer, 9 of the 10 of whom are dead today. Whether it's my baby cousin Kaleo, who died from neuroblastoma exactly 19 years ago this very week, or my Auntie Linda, who was diagnosed with breast cancer when she was my age, these are people in my ohana, not just numbers. So now that we know who, let's move to what is structural racism in the context of all of this. Structural racism has been defined as how society reinforces racial discrimination beyond an individual level by promoting discriminatory values, beliefs, and policies. We see this not only in medicine, but also in the housing sector, education system, and justice system. When it comes to race standards, in 1997, the White House released federal standards that separated for the first time Native Hawaiian or other Pacific Islanders from Asian Americans. In 2010, with the Affordable Care Act, it legally mandated that federally funded healthcare research include all 5 OMB racial categories, including Pacific Islanders. However, we know that this continues to be omitted in healthcare data today. Even in a recent study demonstrating during the COVID era, only 20 of the 50 states were reporting Native Hawaiian and other Pacific Islander data as federally defined. What was most alarming was that of the 20 states that reported, 18 of the 20 showed that across all racial and ethnic categories, Native Hawaiian and other Pacific Islanders were dying of COVID-19 at the highest rates, which reflected even experiences of my own ohana. This was rarely seen in the media, perpetuating structural racism by hiding these truths. This is rampant within medical oncology literature as well, with lack of standardization of inclusion of Native Hawaiian and other Pacific Islander data. Countless studies have aggregated Asian Americans with Pacific Islanders over the decades, suggesting erroneously that Pacific Islanders have superior cancer survival outcomes, which again is not reflective of my community. Data omission, on the other hand, is just as bad as data aggregation, where Indigenous erasure hides our community's health disparities. So that's why when we actually include the data, with this recent publication with my colleagues from the National Cancer Institute, we demonstrate for the first time that young patients with cancer in the United States that are dying at the highest rates are in fact Pacific Islanders and not any other race or ethnic category. This was a fact that's been hidden for decades. So now that we know what structural racism is, let's talk about why this is so important. Let's consider race reporting among phase 2-3 oncology clinical trials. We really should know whether the populations we care for are represented in these studies. If they aren't included, how would we know that the data is truly applicable to the patients that we serve? What my group has found is that across the top medical journals, Native Hawaiian and other Pacific Islanders are the least likely to be reported in these studies. This could be due to comorbidity burden, excluding Pacific Islander patients from entering these clinical trials. I published on how Native Hawaiian and other Pacific Islanders, compared to white and Asian groups, have the highest comorbidity burden among patients with cancer. Even after adjusting for this comorbidity burden, we still see that Native Hawaiian and Pacific Islanders have the worst overall survival. So whether it's the risk of being diagnosed with breast cancer, outcomes from 30-day readmission from surgery after head and neck cancer, or access to care of life-saving brachytherapy treatment for endometrial cancers, we've seen across the board that when we actually include the data, there are significant health disparities that we've been missing because researchers continue to not comply with federal race standards. So finally, I'll mention my research on the Native Hawaiian and other Pacific Islander physician workforce. My research has shown that over the past 20 years, not only are we underrepresented compared to our US Census population, but we're decreasing in our representation. As the first Native Hawaiian MD PhD physician scientist, I take this very seriously and make it my mission to encourage and recruit other Pacific Islanders and Pacific Islander allies into careers of healthcare and research. We know that this is so important because Native Hawaiian and other Pacific Islanders, when we care for our own community members, we've seen the data of improved clinical outcomes through improved communication, improved adherence to medication, and increased number of appointments that patients actually come to, all with racially concordant care. And so those were some of the reasons why I do this research. And together, these were the who, what, and whys of our team's work. To close out, here's some of my future directions. I'm currently completing my MPH because my PhD training was actually in bench research. I want to be able to bridge bench science to clinical research and population science. I want to be an independent physician scientist, obviously with my own NIH funding, but most importantly, I want to be able to amplify Pacific Islander voices so that our stories can further contextualize this data. These are the voices that have been silenced for way too long. And with that, I truly mahalo all of my mentors, mentees, and current funders. I really appreciate this opportunity to be here and to be at Stanford. I hope to establish more collaborators in the future as I transition to the next step in my career. I look forward to connecting with anyone interested in collaborating with our group in the future. And mahalo everyone for your time and attention.